So now testis, scrotum, penis and urethra will go a little fast. Undescended testis. Okay. Undescended testis. Which organ ascends? I told you in the morning. Which organ ascends?
Kidneys.
Yeah. So which organ descends?
Testes.
Testis. So if it doesn't descend, it is known as undescended testis. Ectopic testis. What is ectopic testis? It lies in a different location than normal location. See, there is a predetermined location. Suppose, see here, this is the abdomen, this is the thighs, and this is the scrotum. Finished. Okay. The baby has, the new boy has, the testis from here, it will come across in this, why is it? Come in this manner and it will lodge here. If it is there in this path, then it is an undescended testis. If it goes somewhere else, then it is known as an ectopic testis. What is this retractile testis? Anybody? What is this retractile testis?
So as the word says, is it retracted?
Yeah, it is because of the overaction of cremasteric muscle. Sometimes what happens is the muscle is there, na, cremasteric muscle. It becomes extensively tough. It pulls up the testis up above. So after some time, once the muscle relaxes, the testis will come down in the normal position. So this is known as retractile testis. Okay. Clear?
Okay, sir.
Yeah. Undescended testis is nothing but it is a testis which is lying around the normal path. If it deviates from normal path, it is known as ectopic testis. If it is because of overaction of cremasteric muscle, it is known as retractile testis. Okay. And then most common site of undescended testis, inguinal canal. It always most of the times it gets stuck in the inguinal canal. Most common site of ectopic testis, superficial inguinal pouch, SIP, superficial inguinal pouch and inguinal canal. Just remember these two things. Okay.
Could you please repeat that again?
Yeah. Most common site of undescended testis, it is the inguinal canal. Inguinal canal. Most common site of ectopic testis, it is the superficial inguinal pouch. Okay.
Okay, sir.
So undescended testis people, they will be having normal secondary sexual characters because see testis there are Sertoli cells and Leydig cells. Heard about it, right? Sertoli cells and Leydig cells in the testis. Yes, no?
Yes, sir.
Yes, sir.
So Sertoli cells are more affected. So spermatogenesis is hampered. So the semen will be of poor quality here. Spermatogenesis is hampered. Whereas Leydig cells are not affected. Leydig cells, L for L, less affected. Testosterone is normal. So normal secondary sexual features will be there. So this is a little extra mile, but just it is very important in concept-based questions. Why this happens? Why this does not happen? Why the patient is having normal secondary sexual characters? Because Leydig cells are normal. Because Leydig cells are normal, testosterone is normal. But why the sperm quality is defective? Because Sertoli cells are defective. Investigation of choice for intra-abdominal testis. Anyone?
USG.
No. Think. It is in the intra-abdominal. The testis
Sir,
is lying somewhere inside the abdomen. Intra-abdominal
can
testis.
CT be done?
No CT. No USG. No MRI. No.
Laparoscopy.
Excellent. It is the laparoscopy. You have to put a scope inside and see. Then only you can identify the intra-abdominal testis. So laparoscopy is the answer. Remember, important. Okay. And timing of surgery, it should be done around 1 year. Okay, less than 1 year, it should not be done. So there is a small thing called hemoglobin should be 10. The patient should be around 10 months. It should be around 10 lbs. Okay, so the timing of surgery is around 1 year. Okay, 12 to 18 months to be precise. So there are complications. What happens if there is undescended testis? There are complications like there will be tumor, there will be epididymoarthritis, there will be sterility, impotent sterility, there will be torsion, there is indirect inguinal hernia, and there is seminoma. seminoma will be there. Tumor and seminoma both are same. Tumor, torsion, epididymoarthritis, sterility, indirect inguinal hernia. These are all the complications of ectopic undescended testis. Okay. So procedures. What can be done? So this is the scrotum. So this is the scrotum. The testis can be pulled back and it should be fixed here. The procedure is known as, what is that fixation procedure known as? Orchidopexy. Orchidopexy. It is known as orchidopexy. You have to fix the testis. Okay. Sometimes you have to put it in a pouch, small pouch known as ombridanis pouch. Okay. No need to go into the details, but just remember you have to fix the testis. Orchidopexy. Sorry.
So the pouch name is?
Ombridanis pouch. OMBREDANNE. Ombridanis pouch. Okay. So understand this is over. What is this?
Torsion. Testicular torsion.
Yeah, testicular torsion. Classically, you can see this image. And after detorsion, see torsion in one anti-clockwise. If you clockwise, if you rotate it, there will be detorsion. Okay. So once it detorts, see here, this is the normal testis. This is the torsion testis. But afterwards, what? See, look at this. Both are normal now. Okay. So once you detort it, it will be, the blood supply may increase back again. So for this also you have to detort it and you have to, what surgery you have to do? Detort it and what surgery you have to do? Again it may happen, right? So what surgery you have to do?
Orchidopexy. Orchidopexy.
Orchidopexy. Excellent. So see, it's the same thing. You have to fix the testis so that it should not move. Orchidopexy. And in which patients this torsion is more prone to happen is the patients will have bell clapper testis. See, normal testis is like this, epididymis is like this. If the testis is like this, in this manner, there is no chance of torsion. But the deformity will be bell clapper deformity. So the testis can rotate. Okay, once it rotates, the blood supply will be cut off. There will be edema. Again, it aggravates. Okay, so this bell clapper type of deformity, if it is there, there is high chance that torsion testis will be there. Okay. Yes.
Yes, sir.
There are two types of torsion: intravaginal, extravaginal. Intravaginal is within the tunica vagina. Extravaginal is above the tunica vagina. Torsion. Clinically, how to diagnose? Clinically, the patient will have severe pain. There will be swelling. Pain will be there. Swelling will be there. Edema. Swelling due to edema. And radiologically, how to differentiate torsion? Radiologically, how will you tell that there is torsion?
USG.
USG. Anything specific in USG?
Doppler.
Very good. You need to do a Doppler. Doppler is for flow, arteries and veins. How is the flow? You will come to know that. Okay. So management is detorsion and orchidopexy. Orchidopexy. Will you do? See, the patient is having two testes. One testis underwent torsion. At the same time, you will do the opposite side, or you will wait.
If it's bell clapper, we should do the opposite side too.
If it is,
if it's bell clapper testis, we should do it for the opposite.
So we, as a norm, if one testis goes into detorsion, if one testis goes into torsion, we will always fix the other testis also. Bilateral orchidopexy is done. Okay. So in one exam, in one state exam, it was given a 30-year-old male had torsion testis, torsion right testis. Okay. Listen carefully. He presented to the emergency with right testicular pain. Doppler was done. There is no flow established. He was taken for surgery. After surgery, blood flow was established in both the testes. Treatment of choice is, first option is unilateral orchidopexy. The last option is bilateral orchidopexy. So The fourth option is bilateral orchidopexy. Most of them have marked as unilateral orchidopexy, but the option is bilateral. You have to fix both the testes. Okay.
Okay, sir.
Yeah. So epididymal orchitis in sexually is seen in two groups. In sexually active young males, it is in chlamydia in sexually active young males. In children, older men, and homosexual group, it is organism is Neisseria. It's not necessary, just for completion's sake I have put. And this is important. This is rice water, barley water appearance. Barley water appearance. Barley water appearance. It is seen in spermatocele. Barley water, spermatocele. Can anybody tell me what is this appearance?
Lantern, Chinese lantern.
Yeah, Chinese lantern. Chinese lantern. It is seen in. Chinese lantern is seen in. Epididymal cyst is seen in. Chinese lantern pattern. Epididymal cyst findings are seen.
So, where it is seen? So, barley water sign or Chinese lantern?
Yeah, on transluminoscope. If you put a transluminoscope, this barley water sign is seen. Okay.
Okay, sir.
Both of them, they are seen on that. Hydrocele. What is hydrocele?
Collection of fluid
Fluid
on
collection
tunica
and-
vaginalis.
Tunica vaginalis, there is fluid collection. Okay. So there are, what is this procedure being done here? What is this?
Trans-illumination.
Transluminoscopy. So if you see like this only, there will be barley water sign or there will be Chinese lantern pattern. So these are the 4 types of hydroceles. So this is vaginal hydrocele, only in the tunica vagina, vaginal hydrocele. It is the most common thing, primary vaginal hydrocele. This is infantile hydrocele. See here, from the deep ring, it is completely there, infantile hydrocele. And this series is congenital hydrocele. It is having connection with the peritoneum, congenital hydrocele. And finally, it is only of the cord here, only of the cord. So, encysted hydrocele of the cord. So, we remember it as BICE, BICE. Vaginal, infantile, congenital, encysted. Okay. Vaginal is the most common. Infantile, it is, you can see these images, then you will remember. Up to the deep ring. Into the abdomen, congenital. Only of the cord, it is encysted hydrocele of the cord. So what is the treatment? Any medicines for hydrocele?
No.
Yes, no?
Only surgery.
Only surgery, no medicines. Okay. So what are the treatment options?
Erythrotomy.
Sorry? What
Can we see
surgeries?
Can we see the previous slide just for 1 second, sir?
Sorry?
Can we see the previous slide just for 1
Yeah.
second?
Yeah. Once I'll erase this, you can see it clearly.
Okay, sir. Thank you, sir.
Vaginal, infantile, congenital. E is, what is E?
Ancestor.
Encysted. Yes. The treatment of hydrocele. What is the treatment of hydrocele?
Erythrotomy. No application of sac.
Lord's plication,
Of sac.
Jaboule's procedure,
Excision of sac.
Sharma's excision. There are 3 procedures only. One is plication. What is plication? In small and moderate hydroceles, there will be covering like this. Okay, there will be covering like this. There is swelling here. So you just plicate. You just take sutures, plicate it. It will be enough. In small to medium hydroceles. Jaboule's procedure, you'll just open the sac, turn it around, and suture it. so that the space will be exposed to lymphatics and the fluid will get drained. Jabulase procedure. And Sharma, Indian surgeon, he told to excise the sac completely. These are 3 types of surgeries for hydrocele: Lord's plication, Jabulase procedures, and Sharma's plication, Sharma's excision. So this is a varicocele. What is varicocele? Clinically, how it is felt?
Bag of worms.
Yeah, bag of worms. Bag of worms. Okay. See, these are the normal. Suppose this is the testis, an artery will be bringing the blood and a vein will be taking away the blood. These veins will get dilated. So this is known as varicocele. So in varicoceles, there is always left predominance. Left is more prone to have varicocele than the right side. Why? Left
Because
side
left is
varicoceles are
more-
more common.
Left side is more descended down. So
No. It is also again with the same with the left testicular vein. Right testicular vein, it opens directly into the IVC, whereas left testicular vein opens into the
Renal vein.
left renal vein. Yes. So there is, because of these two, here it is simply it is opening directly into the IVC. So pressures are less. Here the pressures are more. It is opening into the renal vein and then it is opening into the IVC. So the pressures are more here. Okay. So that is the reason why left side it is more common. And also the sigmoid colon is pressing there. Sigmoid colon lies on the left renal vein, okay, left gonadal vein. So because of this pressure also, these are all hypotheses. Because of this pressure also, left side varicocele is more common. Okay. On examination, you will find the bag of worms appearance. Investigation of choice is by doing a Doppler. Stage 1, stage 2, stage 3. Stage 1 only on Doppler. Stage 2 they are palpable. Stage 3 they are visible. If you can see, if they are visible, that is stage 3. Management of varicocele. What is the management of varicocele? Can anybody tell me? There are dilated veins. Veins are dilated. So how to do it? What to do?
Venous drainage.
You will just do a varicocelectomy. Varicocelectomy. That means you will just ligate the vessels. That's all. You just ligate the vessels. Only one you will remain, keep it open so that it is enough for drainage. All the others you will ligate it off. Okay, that is a varicocelectomy. Okay, that is a management of choice. And a named surgery is there, Paloma's operation. Paloma's operation, that is retroperitoneal ligation of varicocelectomy. Retroperitoneal ligation of varicose veins. That is known as Paloma's operation. Testicular tumors. Most common testicular tumor?
Seminoma.
Seminoma. Okay. Most common testicular tumor in young people, like young in children and old. Only 3 questions here. Seminoma is the most common. Good. In young children, what is that? In old people, what is that? In young, it is yolk sac tumor. Remember, in young, it is yolk sac tumor. Yolk sac tumor. In old, it is lymphoma. Remember these MCQs? 3 MCQs. Most common testicular tumor, if they ask you, it is also like the Wilms tumor. Only one word, the answer changes. Most common tumor, if they ask you, it is seminoma. Most common in young children, it is yolk sac tumor. Most common in old people, it is lymphoma. And what is the age group at which testicular tumors are most commonly seen? Age group 30 to 40 years females, 30 to 40 year males. Okay, 30 to 40 males, prepubertal males also. Clinical features, testicular tumor, what is the clinical feature? Yes.
Heaviness in the scrotum.
Sorry?
Heaviness in scrotum.
Heaviness in the scrotum, yeah. Heaviness in the scrotum, swelling in the scrotum. These are the 2 things, right? heaviness and swelling. And the sensation of the testis is lost. Normally, anybody can tell me what is that sensation of the testis known as? If you press a testis, what is that sensation the patient will feel, or the person will feel? Sickening sensation. Loss of this sickening sensation also is a sign of testicular tumor. Okay, 3 things: heaviness of the scrotum, swelling of the scrotum, and loss of this sickening sensation. And tumor markers. What is the tumor marker for prostate cancer?
PSA.
PSA. In the same way, for testicular tumor, there are 3 tumor markers. Lab, LAB, lab. L is LDH, A is alpha fetoprotein, B is beta HCG. Okay, so tumor markers are important. Here they are so important that what is TNM staging?
Tumor node metastasis.
Tumor node and metastasis. But for testicular tumor, it is TNMS. S is tumor markers. Okay, TNMS. S is tumor markers. So that is the importance of tumor markers here. So here I want to discuss 2 important things. Suppose a patient is having a scrotal swelling. Okay, so you can go directly for surgery, or you want to do some biopsy.
Biopsy.
Directly.
Here also biopsy is contraindicated. Okay, transscrotal biopsy. If this is the scrotum, if you want to put a needle like this, if you want to put a biopsy gun like this, it is contraindicated. Why it is contraindicated? Can anybody tell me?
Right.
Sorry?
Bleeding.
Okay, not so. Bleeding we can control. No.
Testis is movable.
Sorry?
Mobile testis movable.
Sorry, not loudly. Loudly.
Metastasis.
Yeah. See here. Listen carefully. Very important. I hope everybody is following. This is the testis. The patient is having a testicular malignancy. Okay. So testicular malignancy spreads to lymph nodes. It will spread to in this way. See the green pointer going. It will spread through para-aortic lymph nodes, umbilical, para-caval lymph nodes. This is the way testicular lymph nodes spread. This is the way testicular lymph nodes spread. Whereas the scrotal skin is like this. The scrotal skin will spread to inguinal lymph nodes. So if you put something here, there will be tumor sample, tumor will be spread here, and the lymphatic supply will be hampered. It will not go in its usual direction. It will go haphazard. It will go this way. It will go in multiple directions. So after surgery, if you want to give chemotherapy or radiotherapy, it will be very difficult. Okay, is it clear?
Yes, sir.
Yes. Others also? Yes. No.
Yes, sir.
Yes, sir.
See, the
Yes, sir.
lymphatic supply of the scrotal skin is different, and the lymphatic supply of the testis is different. So if you put in a needle through it, it will alter the lymphatic pattern. So afterwards, if you want to give radiation, it will be difficult for you to give the lymph nodes. It will be difficult for you to give the radiation. Okay. So we should never do a transscrotal biopsy. This is avoided. So how to differentiate whether it is, so you have opened the testis. Once you open the testis, you can just bivalve the testis, open it and see whether there is malignancy inside or not. This is known as Chivasu maneuver. Chivasu maneuver. Okay. Open the testis, look inside, and if you want to send a biopsy at that time, but not before. You should not never do a transscrotal biopsy. Okay. So the management is do a orchidectomy. It can be done 2 ways. One is scrotal orchidectomy, one is high inguinal orchidectomy. Which you will prefer, scrotal or high inguinal?
High inguinal.
High inguinal only. Scrotal is never, because the same thing. I'm telling you not to put a needle or not to put a biopsy inside. So how can you incise the scrotum? Again, the lymph nodes will be hampered, right? So we'll give an incision in the inguinal region above the lymph nodes, and just we'll plug the testis outside and we'll remove it. Okay? Clear this concept?
Okay. Yes, sir.
Everybody? If you have doubt, I'll tell you once again, but just follow it nicely. Yes, no?
Yes, sir.
Yes, sir.
Okay. So what is this? Spotter. It is a, what is this? Black part.
Black plaque over the scrotum.
Necrosis.
Necrosis. Yeah, what is that? If suppose some part becomes necrosed, starts with G.
Gangrene.
Is it
Yeah,
like
it is gangrene.
Yeah.
It is
okay?
Fournier's gangrene. Fournier's gangrene. Fournier's gangrene. In diabetes people, in diabetes patients, the skin becomes black, necrotic. Okay, this is Fournier's gangrene. Okay, so we have to excise this part off completely. The whatever the skin is excised and a flap is placed. Okay, this is the testis. Testis is not affected. Okay, the testis in this condition, the testis are known as shameless testis. They are exposed. They are known as shameless testis. Okay, in Fournier's gangrene, the testis are exposed completely. They are known as shameless testis. What is this? What is that? This you all know, right? What is this?
Brinjal.
Other name for brinjal?
Eggplant.
Egg?
Eggplant.
Eggplant. Okay. It is also looking like this only, right? So there is penile fracture. This is a penile fracture. There is not only fracture to the bone, but there is fracture to the penis also. This penile fracture, it is looking like this, eggplant deformity. Okay. So normally what is there inside the penis? This is also a spotter. See, cut section of penis. There is a corpus. What are the three things?
Corpus cavernosum.
Corpus,
Cavernosum spongiosum.
cavernosus, and corpus spongiosa. Is corpus spongiosa will have the urethra. Corpus cavernosa will have the blood sinuses. So whenever there is erection, the two cavernous sinuses will be filled with blood. Okay, then only there will be erection. And corpus spongiosum, there will be urethra. Urethra will be lying, so urine will come through it. So once these corpora cavernosa walls get breached, okay, there will be seepage of blood here. This is known as penile fracture. Okay, this is eggplant deformity, classic eggplant deformity. So the external urethral meatus should be lying here. External urinary meatus should be lying here. Okay, this is the normal external urinary meatus. Suppose if it is lying somewhere here, what is known as? Anybody?
Hypospadias.
Hypospadias. Very good. It is known as hypospadias. 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 Okay. Here, the opening is not in the original place. It is somewhere below. Okay. So the most common, one question only from here. The most common type of, it may be in the glandular level, subcoronal, distal penile, mid shaft, anywhere. But the most common is glandular. It is on the glans, glandular. Okay. Hypospadias. Most common site, glandular. Just remember that. This, what is this? This is the bladder. It is completely outside. It is extrophy of bladder. It is a little, just if you remember, otherwise no need, but just it is known as exostrophy of the bladder. The bladder is completely outside. There is no covering of the bladder. Okay, exostrophy of the bladder. Bladder exostrophy. Phimosis. What is phimosis?
Inability to retract.
Inability to retract the prepuce. Okay, so see here, this is a device known as the circumcision device, plastibule. This is known as a plastibule, which is used to cut it off, cut the extra, cut the skin or the glands, that is the prepuce. And see this condition, what is this? What is this?
Edematous paraphimosis.
Paraphimosis. Once you retract it and leave it like that, there will be a constriction ring formed and the prepuce will be edematous. It won't come forward. So this is paraphimosis. This is known as paraphimosis. So remember, what is phimosis? Inability to retract the prepuce back. What is paraphimosis? It is the retracted retracted prepuce will not come forward. Peyronie's disease. This is just the penis will be in a slanty position. It is in a bend. The penis will bend during erection. This is Peyronie's disease. Priapism is erection. This is all known. Penile cancer. PLT. Okay. In penile cancer, the most important prognostic factor in penile cancer. This is the fourth one. What is the most important prognostic factor in breast cancer?
Axial node involvement.
Most important prognostic factor in Wilms tumor.
Histology.
Histology.
Most important factor of Wilms tumor if histology is not given.
Stage.
Most important prognostic factor of sarcoma. Sarcoma? Grade. The most important prognostic factor in penile cancer. It is the inguinal lymph node status. Inguinal lymph node status. Inguinal lymph node status. Okay, here also lymph node. For breast it is the axillary lymph node. For penile it is the inguinal lymph node. And the most common mortality, cause of mortality in penile cancer. Can anybody tell me how a penile cancer patient dies?
Shock.
Unable to use any.
No, no. It is very rare and you will not expect this. It is something which we will not expect. This is the penis. Suppose the patient has a cancer here. This is the legs. This is the inguinal lymph nodes. The cancer spreads to the inguinal lymph nodes here. Okay. So there will be a femoral artery here. The lymph nodes will be just on the femoral artery. There will be erosion of the femoral artery wall. So the patient will bleed to death. Okay. So this is an MCQ. They'll ask you, most common cause of mortality is femoral artery bleed. Okay, remember, it is not, we can't think like same in prostate cancer. I told you orchidectomy. It is somewhere unrelated. It also looks unrelated. How a penile cancer patient dies with femoral artery and your femoral artery bleed. But this happens. Penile cancer spreads to inguinal lymph nodes. The inguinal lymph nodes, femoral artery wall gets eroded and the patient will bleed to death. Okay? Yes, no?
Yes, sir. And the most important prognostic factor is inguinal node involvement.
Inguinal lymph node is inguinal lymph node. Okay, this. Yeah, tell me. What is this? Complication of this condition, all except.
Direct hernia.
What is this condition? No, what is this condition?
Undescended testes.
Undescended testis. Okay, done. So what are the various complications of undescended testis? For that there is a mnemonic I told you. Testis. T is?
Torsion.
Torsion. One T is over. Another T is?
Tumor.
Trauma.
Torsion, trauma.
S is? Seminoma. In another S is? Sterility. E is? Epididymoarthritis. I is?
Indirect
Indirect inguinal hernia. Okay, so this direct hernia is not the correct option. Okay, direct hernia is not the correct option. Indirect hernia only will be there. So identify what is this. Don't go into this, but what is this?
Prepuce.
Sorry?
Refuse is it?
This is the prepuce, okay. This is the prepuce here, hooded prepuce. But what is this condition?
Hypospadias.
It is a hypospadias. Very good. So, what is wrong in the picture? There is a dorsal hood is there, ventral cord is there, that curvature is there, ventral cord, pelvis is curved. Is the opening on the dorsal thing or ventral thing?
Ventral opening.
It's a ventral opening. Hypospadias is ventral. It is below. So that is the answer. Okay. And finally, what is the proximal margin required? So before this, I'll just tell you. Suppose this is a penile cancer. Penile cancer, if it lies like this, what you will do? If the tumor is like this, what you will do? For option A, what you will do? For option B, what you will do? This is A, this is B. What are the treatment options?
You have to excise it, right, sir?
Yeah, you have to
Excision.
excise it. That's sure. A also we have to excise. B also we have to excise.
Partial and
Yeah, for A you can do a partial penectomy. For B you have to do a radical penectomy. That's what I wanted. A partial penectomy and B radical penectomy. Earlier days these type of questions used to be asked. Margins, proximal margin, distal margin. But nowadays there is no concept of this margins. Nowadays everything is single cell. If there is single cell also, it's okay. Negative margins is all we want. That's all. So if the tumor is lying on the glans, we can go for partial penectomy. If it occupies the entire length, if we can't give a sufficient length for the patient to do two things. One is to stand and void. The patient should be able to stand and void. This male patient, right? The patient should be able to stand and void. Second thing, he has to for erection and intercourse. If these two things are there, you can go for partial penectomy. If you are not able to give this, go for a radical penectomy. Clear? Yes, no?
Okay, sir.
Yes, sir.
Yeah.